As always, we appreciate you being with us today on this episode of the Healthcare Leadership Excellence Podcast. I am excited about today's guest. Um, One of the reasons I'm excited is that we're going to talk about a theme that most leaders run screaming from the topic because it so intimidates them. And sometimes the responses for this topic can seem a little bit warm and fuzzy to many leaders, and we're going to dig into that a bit today. But what I love is our guest today has led at high levels in major organizations with thousands of people reporting into him. And yet his background allows for a compassionate yet practical view of this theme, which over the next two episodes, we're going to talk to him. There's no way we can fit this into one episode. So this gentleman was very kind in giving us 2 hours of his time. And I would like to welcome our guest, Ed Speedling, to our program today. Ed, thanks for the time you spent in the pre-calls and for the time you'll take over the next couple of episodes.
Yes, sir. Well, Carl, I appreciate the opportunity, and I'm looking forward to this conversation. Like you said, it's probably the elephant in most healthcare hospital, system, you name it, right? Physicians' practices. I mean, this is one that hopefully, right, in podcast history will go down as something that resonates with a lot of folks. So.
Exactly. So just give our listeners a brief thumbnail sketch of Ed's background and what leads you to be with us today.
Yeah, absolutely. So currently, I am the principal executive advisor for ES Healthcare Consulting, which is my business. I'm working with a lot of clients like hospitals, health systems, certainly small mom and pop organizations like partial hospitalization and intensive outpatient programs. I'm also working with some private equity groups and helping them to look at and assess companies that they're interested in purchasing from the standpoint of, what's good, what's bad, what's going to give us a quality business and make it sustainable. But I think probably the most important thing today is to just note that I'm a clinician by background. I work directly with children and families for a good portion of my career. That's what has motivated me. That's my why, right, is to continue to help families and patients all across the country. And so ES Healthcare Consulting is really dedicated to finding solutions together, partnering with the C-suite or other leadership, and really working together to find the right answers to the questions that they have at that point in time.
So we talked in our pre-call about
Mhm.
an experience I had years ago
Yep.
with this senior level vice president who could negotiate with the toughest of opponents. Absolutely. In fact, he was written about in our local paper here in Portland, Oregon, the Oregonian, as one of the most feared negotiators
Mhm.
this large organization had.
Right.
And those were not loose words from the people across the table. I also had had the experience of being across the table from him, and he ran the room.
Mm.
And the story, listeners, that I shared with Ed was one day I got this call and I recognized his voice, and we'll call him John for confidentiality, even though it's long past. John, what's wrong? Carl, there's a woman in my office and she's crying and I don't know what to do and I'm outside the door. Can you help me?
Mm.
Now, this is a person, again, to our listeners, who could absolutely bring the other side of the table to their knees. And yet, a woman with an very difficult situation, a mental health issue, apparently, had him completely lost.
Mhm.
So, Ed, give us some thoughts into why behavioral health just makes some of the best leaders go deer in the headlights.
Yeah, absolutely. I mean, I think your example is fantastic in that scenario, whether you're a senior VP or you're a middle management director or manager, happens every day, right? And I think that we established in healthcare a long time ago an open door policy. We all remember that term. We all, love the idea of, hey, if you're an employee and you work on my team, please come in. Please let me know how you're doing. Feel free to ask questions, check in. And so that open invitation, I think, leads to some of this, right? Where somebody feels like they can and should be able to walk into their leader's office and share something that might be vulnerable or bothering them or might be impacting the team, or, they're concerned about something. And unfortunately, there's no playbook, right, that most organizations have for the empathy, the listening, the ability to put everything down, right? Put our smartphone down, put the email away, listen, right? Make eye contact with that individual and really focus on what's important to them in that moment, which is that they're heard and that they feel like they have some buy-in from their leader, their champion, or a leader in the company, right? It doesn't matter who it is, but that's the first thing I think is that everybody that comes to us, and we talked about this a little bit in our prep call, is looking for a sense of belonging and is looking for that feeling of, hey, if I come to this person, I'm going to be able to communicate what's on my chest without fear of anything happening, without fear of, them judging me. And I think that's a really important point and a key part of healthcare success is having teammates feel that way about each other, but more importantly, having institutional policy, procedure, structure, and even buy-in, right, from board down, that this is an important process. This is an important, almost side category of employee recognition, retention, and engagement that people really need to commit to.
So walk us through, because again, the point of our podcast is always giving our listeners something that they can make an actionable item ASAP.
Absolutely. Yeah.
So
So, I think,
walk us through,
mhm,
as you said, from board on down, because we've got listeners pretty well at every level. How does an organization put together a comprehensive plan that addresses mental health
sure.
without getting in? Because this is what I hear. Well, Carl, those are sensitive issues and we don't want to compliance liability. We can't get into those issues.
Mhm.
And yet they seem to ignore that those issues are at the work site every single day.
Right.
So
Right.
walk us through that conundrum here. Because
Yeah.
you
I think,
dealt with
first of all, there's some guiding principles, right, that I think we should all agree to and align with. And the first would be, mental health is health, right? Let's start there. Leadership needs to make it a strategic priority. So getting board support and buy-in at the top affects your full culture, your full performance, and certainly organizational stability long term, just like you said, right? We see it every day. It's going to find you, it's going to be there. And then the second thing is prevention. We talk about prevention right now in terms of go to your primary care doctor, right? There's insurance incentives now to do all sorts of preventive stuff. Well, prevention and early intervention is very similar in mental health, right? If you commit to a proactive approach and somebody has the ability to reach out to whether it's EAP, their leader, it might be some sort of subclinical tool, right? Lots of apps exist now for healthcare systems or insurance companies. What are we putting in front of our employees that helps them connect with resources in real time? So that's part of the prevention and early intervention. But then you have biannual board meetings, right? What are we measuring here? What are we looking for? What metrics can we actually track to see how our prevention strategy is working? What is that policy doing, right? So it would be things like, I think, participation rates in mental health programs that you're offering, aggregating stress and workload metrics, right? So when you do your employee survey and you ask a question about stress and or workload, what are people saying? How are they balancing that? Are these tools, is this policy, is this new alignment helping with that? And then finally, it would be, are there recommendations for systemic improvements, right? Whether it's from that survey or it's from the data, whatever it is, the point would be, please use the data to improve the systems, to create accountability and visibility for a governance effort, right? So governance is the responsibility of everybody. And so if you've got that big picture and that policy all the way down, it's really hard to ignore how to handle something. And it's easier to use the tools that are in front of you.
So one of the things you said early on in that explanation that hit me is mental health is health.
Yes.
We put mental in front of it, but it is health.
Yeah, absolutely.
And poor mental health affects physical health. Physical health hits our work I mean, it just, you
Absolutely.
see it change.
Absolutely.
So one thing, and I share a common background in my deep past of clinical social work,
Mhm.
so I'm very familiar with that. Why do you think, especially with all we've seen over the last few years, decades, why is there still such a stigma around the mental health part of health overall? I mean, if I have a knee replacement, it's wow, Carl, way to go, no problem, we'll have the crutches. It's almost wow, we're with you. But man, I had to take a couple of weeks off because my dad's death really hit me harder. I had one senior executive, Ed, pull me aside and say, "Is John going to need more than the 3 days leave for grief?" And it was a loss of a child accidentally. And it was kind of, well, that's 72 hours. That's our so walk us through why we still have these false expectations, why there's still a stigma about my grief over my dad
Yeah.
versus almost a badge of honor of my knee replacement due to high school football injury. Walk us through that. Help us out here.
Yeah, I mean, despite the public health campaigns and some of the online celebrities who are representing mental health and things these days, in health systems and really just health companies in general, I think I would still say that it's still not normalized, right? And so the bottom line is that more conversation, ground level education as a part of your annual training should be happening, right? This is what mental health is. These are some of the diagnoses. This is what it looks like to seek help and why it's okay to seek help, and comparing it to a cardiac event or comparing it to an orthopedic injury when you seek help, right? And reduce that fear, reduce the fear of help seeking, which is really, really critical. So the more it can be normalized across the organization in conversation, whether that's at the water cooler or on the staff, you know, um, board that you have in the break rooms, it should be something that is part of grand rounds. It should be something that's part of board meetings. And I think I mentioned this to you previously, Carl. When I was working in a nonprofit health system, I worked very closely to do an anti-stigma campaign across the entire system. And that was in conjunction with the hospital foundations for 10 hospitals. And so we went, myself and one of the representative from operations and somebody that led behavioral health, actually one of the psychiatrists, and we created scripting to give the top three scenarios in mental health that you would encounter as a leader across a health system. So it was simple things like financial stress at home, which creates anxiety, which can create depression, which can create a rift in a marriage, right? Very common scenario. Substance abuse, right? You have a child, a teenager who's experimenting with drugs, and suddenly they need to go to the ER because they've, taken something and nobody knows what's wrong. Well, suddenly you're thrust into this environment of seeking help for drug treatment, right? And so that was another one of the scenarios. And then the third was a mother who had children removed from her, got them back, but was being monitored by social services and getting mental health treatment, all while having a job as a healthcare technician, right? Sort of one of the lower level positions, but a very real scenario, right? Making minimum wage, doing their best to raise their kids, get through their circumstances. And we presented each of those to the hospital boards in order to just normalize, right, what this looks like on a daily basis and to have a conversation about why we needed to raise, I think at the time it was $1 million across the entire system to hire two NPs, a psychiatrist, and to develop some telehealth resources so that the EAP would be more robust. There was better access to care. If somebody didn't need to be inpatient in one of our inpatient beds for psychiatry, we could actually see them in the ER, triage them, and send them to outpatient care. And so the purpose of the funds was really to develop those services across the system and help not only employees, but also patients, and everybody bought in, as you can imagine, right? And some of that helped to alleviate that pain point you described of why is this still being considered something we should be fearful of or fearful of talking about, or the fact that I'm acknowledging that I might have some financial stress is not okay, right? And it sort of goes back to the belonging. We're all experiencing it. So let's normalize it. Let's talk about it more. So that's how I would answer that question is It's about normalizing, but widespread education. And if you can find a rallying point within your system, just like I described, whether it's a foundation or it's raising monies to enhance what you offer to your employees, even, that's a great way to start the ball rolling without question.
So, as I mentioned to our listeners, we are going to have two episodes here, and we're going to go on a couple of themes, and you'll hear it in the second, you'll hear it right now. But I think repetition is one of the bases for being an elite organization. So, bear with
Yes.
the repetition. Ed, in our pre-call, you said something that really just rang my bell as something we've got to dig in on this. Um, there are still those who give surface credence to, well, yeah, everyone belongs in our organization, etc. And then they drop this wagon load of to-dos on them, which doesn't make anyone feel belong, just dumped on. Talk to us about why belonging is a key. And
Hmm.
let's just make it, you're my
Yeah.
boss, I'm your employee, and because I know there are people listening to us right now, Carl, they're there to do a job. We hire professional people. We're not going to handhold. We're in healthcare, so we are running fast right now. We're trying to keep the doors open. And so this belonging bit, yeah, at the work site, I'm not so sure. Take us back.
Yeah. Yeah. I mean, I think it starts with, the training I had as a social worker in kind of thinking about systems and looking at what we call, right, the biopsychosocial components of anybody's life or, family system, ecosystem, however you want to put it. And so I would start with saying that the biological, psychological, and social components of everybody's life are very similar. And knowing that everybody needs psychological safety in order to feel comfortable, whether it's functioning in your marriage, whether it's working with your kids and being with your kids, or it's at the workplace. That's the fundamental starting place. Psychological safety and belonging kind of coexist together in harmony when they're going good. And without that belonging, you can't really in a workplace develop people or bring them along to where you want to be unless you've already got that foundation, right? So it's so critical as a young leader myself. I didn't do that very well. I'm just going to use my own example. But one of the things I did was I thought that I could lead and sort of demand, have a great idea, bring the people with me. Well, lo and behold, as we know, right, that doesn't work so well. And so, I'm a good example of somebody who learned from that, I hope, and then led very differently. And I think my teams along the way would tell you, Ed over here didn't have us necessarily belonging, but Ed over here, a few years later, thankfully did. And the difference was better performance, better love of the job, feeling like they were heard and that they were committed to the team because the team stood for something. The team stood for, right, in that case, it was really our outpatient ambulatory services, but they stood for the best of what they could give to those patients and those communities that they were in. And they did a fantastic job with it. And I think that's where the belonging and the psychological safety were played out and demonstrated in metrics across that service line where people really showed, hey, if we're working together and we share these ideas together and we feel like a team and act like a team, truly, these are the results that we can show and we can continue to have. And so I think that's one of the critical parts is the psychological safety goes hand in hand with belonging. And when you have that, then you can really start to outperform other teams, other organizations, and just do better yourselves and feel better about it.
So, as someone who has led hundreds and thousands of employees, let's run a hypothetical here. And I didn't talk about this in the pre-call because it just hit. So we can always edit this if you don't want to go down this path. But what I'd like to do is I'm the mid-level manager that is he I have the art of
Mm.
results polished.
Okay.
Leave a trail of tears behind me with my, but I get things done.
Yeah.
And so you've just presented as my senior vice president, you've just presented to me this bit about belonging. And I'm here saying, Ed, I that's just not my personality. I'm
Mhm.
just
Mhm.
and I blame it on everything, from the sunrise to the sunset. But it's just, and I hear your point, but I'm just really not going to do that. I don't handhold my people,
Mhm.
etc. And I know there's people listening that are thinking, yes, that's exactly the conversation I have to have with my Carl.
Yeah.
So walk us through how you would sit Carl down
Yeah.
and help me to understand that, um and I have a hard time with my truth and your truth because I think there's some, Carl, don't quit, don't argue about things that are very obvious. So how do you talk to me as if I was really that employee and
Mhm.
help me come to a realization that my way is just long term not going to work. It's not
Mhm.
sustainable. So
Yeah, yeah,
don't you
yeah. I
think?
mean, I think I would start with the analogy that individual performers are often promoted and certainly get promoted and put in leadership roles where their performance and the way that they did it, the type A personality, the go-getter, the long hours, the commitment to not necessarily team and people, but to product and outcome got them to where they are, right? And so it's hard to unlearn that until you're in the real throes of having a full-blown team crisis where you've lost the credibility. People don't hear your ideas anymore and they're pushing back. And so that's where oftentimes the conversation with that senior vice president comes in and they're saying, listen, Carl, I need you to think about this differently. We might need to get you some coaching. We may need to revisit sort of what your leadership profile told us about your, ability to play nice with other people. But certainly, you know, um, I think the approach is really you have to look at it like we're not the authority, even though we are in that chair. We need the team to help solve the problem. And so being able to say that and being comfortable in that is a very different place than being that top performer, that number one, asset that the VP is going to call on every time because you can get the job done. But being vulnerable, learning how to be vulnerable, and even getting some of those additional leadership skills that, as you know, are critical and oftentimes come out in focus groups when you're sitting down with HR and you've got the group of employees and you're saying, tell us about the bull in the china shop, right? Tell us what's going on. What's scaring you? Is it fear leading? What's happening? And that's what you hear, unfortunately. So we're leading from a flawed person standpoint, right? And acknowledging that as a leader can be very scary, but can be the most beneficial thing you could ever do for your team to open that up and say, I need you to help me fill these gaps, find these solutions. And that's the answer. So going back to the scenario, if that person is not receptive to that, which some people are not, you want to give them options, right? There might be executive coaching as an opportunity, somebody that they can connect with, that they do feel comfortable opening up about some of these harder issues. It's really hard to do in a group when you don't want to lose that position, right? That authority. But also structured reflection time, right? I would say, listen, have you thought about this? Have you really heard the feedback? Have you looked at your teams? Yeah, you're hitting on this metric, but there's some static back here we're hearing, right? We're seeing some things where people are looking at maybe other jobs we've even heard. So, is that something that will resonate? And then also checking in with that leader. I mean, just saying to them, how are you doing, right? Maybe
Yes.
they don't have the capacity emotionally, sleep wise, family life wise. We don't know what's going on. So, organizationally, it is imperative to check in on them to understand what might be driving their lack of wanting to do something different or their inability to hear feedback, which oftentimes is more the case than not. And we can get them to move the needle, right? We can coach them, we can work with them, we can support them. So it's usually not the end all be all, but it is a hard reckoning point when somebody gets to that place sometimes where you have to really um, give them the time to really adjust, but also understand what's needed in that moment.
So you said something that I want to dig in on a bit. In the last 2 months, I've had two surgeons, brilliant people,
Yeah.
were on a performance improvement plan. And they told me, and I asked them, so what is the committee? Usually it's the medical executive committee or the medical staff office. What have they what have they done in their contacts with you over this year to let you know where you are in the process?
Mhm.
And both of them said, I haven't heard anything.
Mhm.
You've
Mhm.
been my only contact.
Mhm.
And I was stunned because I thought there would be follow through. So,
Sure.
speaking to someone who has led thousands, what advice, counsel, coaching, whatever phrase we want to use, would you give to that high level manager who's thinking, that's why we have you as a coach, Carl. You take care
Mhm.
of that. You just tell us if there's any sideways and when the PIP, the performance improvement plan, is over. Yet that's only half the equation. What coaching could you give to that executive who's thinking, oh, Ed just said follow up and I don't. Any coaching on follow up?
Yeah, I mean, I think it's got to be intentional, it's got to be scheduled, and it has to be part of the routine that's built into leadership, right? And so I think whenever I would start a position myself, I would always sort of get the lay of the land. I would always talk to the, managers around me, the previous leader if they were available, and get a sense of who needed that extra help, who was on the performance plan, why were they on it, and what did I need to know about where they were in that process. And so I think it's always incumbent upon that leader to really say, am I carving out the time necessary to really ask these questions, to really sit with them and process where they are still struggling and what other resources do we have? Again, going back to organizational culture, if you have a policy, a procedure, a process built into the organization that starts at orientation and goes all the way through the process of employment, you don't have these issues as much as you do when you don't have that as a clear cut expectation and also opportunity for resources internally. So I think that person would just need to we want to sit down and look at how are you using your time, how are you following up, is it them or is it that you don't have this blocked on your calendar and you're too busy because it's easier to do that, as we all know in some cases. And so, right, what's your commitment here? And so I think assessing that, as well as then saying, if you are committed to this time, let's assume they're doing what they're supposed to and things aren't moving. Is there another leader that could look at this differently? Is there a third party person, whether it's human resources, organizational development? Of course, that would be top choice. But if there's not, who else could come in and be a coach and help with the situation and really get this to continue to progress, right? Because we want you to stay. This is something we believe can be workable, right? Now, if it's not, that's a different story, as you know. But in most cases, it's workable.
Another thing you said a couple of minutes ago, and I think there should be some pro forma about when people really listen to podcasts, is generally on the treadmill, driving to work,
Yes. Yep.
rarely in a place where they can take notes.
Yep.
And you said something that really is notable. And you mentioned two two lanes, team and people
Mhm.
and product and outcome.
Yep.
And you link those, at least in Carl's mind, as I heard you, that team and people is absolutely bedrock linked to product and outcome. Did I hear that well?
100%. Absolutely. Yep.
So could you dig in a bit on what the research and your experience shows on how you can't have sustainable product and outcome without strong team and people? And you might think, Carl, I've already made that point. But to our
Mhm.
treadmill and driving audience, could you just dig in again on this? Because listeners, if you hear nothing else in this podcast, right here is a huge key. Team
Mhm.
and people, product and outcome. Thought?
Yeah, I mean, there's no successful organizations that are losing employees at a major clip, right? So the link between the belonging and the full team belonging and having an understanding of how we address issues, how we work together leads to that successful product and ultimately the successful outcome for the patients that we're serving and the communities that we're serving. So if we take any one of those pieces away, right, from people or the team, and we lose that sense, what research has shown is that your expenses are going to go through the roof, right? You're going to be in a major retention situation. You're going to be hiring and hiring and hiring and never finding enough people or the right people to fill the gaps to get to that successful product and outcome that you may have experienced. And so that link is really absolutely crucial. And one of the other things I think that is going on today is there the ability to replace people to some extent with artificial intelligence or machine learning, whatever you want to call it? And the answer really is no, because you still need people to have the synergies and to be the real respondents and the in-person folks that are treating patients. But you can gain efficiencies that would help your team be more efficient, that would help your people maybe be more satisfied, more engaged, take a burden administratively off of them. But ultimately, that product success, that outcome success is still predicated by real humans and the real human interactions with patients and families. So that's one of the things I see all the time right now is how can I find that product that will help me reduce headcount or will help me, you know, maybe create more efficiency and hopefully impact the outcome on the other end. And what employees are seeing is that, well, maybe my skills will atrophy, maybe medical legally, right, responsibility will come off of me and shift to somewhere else. And physicians in particular are very against that, right? They want to make sure that there's not that loss of medical authority, and rightly so. They're very well trained, spend a lot of time in school, they know what treatment should look like. But if you mix those things up or conflate them, then you're going to be in a world of hurt. And so that's where outcomes and product can fall apart to some extent without the right oversight, controls, and certainly not just going with a singular product that you believe can replace the human element. And so those are core elements to that team, people, product, and outcomes equation that oftentimes we are talking about. But the way things are moving so fast, I think a lot of systems and hospitals are making decisions that may need to be undone. And because they feel like they need to get ahead. But you need to test it. You need to obviously sit through what the machine learning can do, the capabilities to really understand it and to use it effectively.
So, to our listeners, our part two of this episode is going to be an incredibly deep dive into this aspect, and we welcome you to be with us on that. We're going to close out today with we're going to change lanes completely. Um, and I'll introduce it. We've talked about this, so this is not going to blindside you. But if you want to get the temperature in the room
Mhm.
just through the roof in one simple phrase, um, it's the phrase private equity and healthcare. I
Yeah,
mean, it
yeah.
just uh, Darth Vader, the dark side, just a definition of evil is, in many people's mind,
Mhm.
is private equity.
Mhm.
And yet you've worked in healthcare, you have a background in the compassionate side of healthcare, which is
Mhm.
the clinical social work and the behavioral sciences. And I'd like you just to take a couple of minutes as we wrap up, respecting your time this morning.
Yeah.
Talk to us about some of the myths and the realities of the involvement of private equity. Um, because there's that biblical phrase, it's the love of money that is the root of all evil, not money itself. So
Yep.
I'm sure they're private equity investors that have nothing but their own interest in mind.
Mhm.
And I'm sure there are those that are not. So could you walk us through and clarify from your consulting and experiential role, what are we
Mhm.
looking at here?
Yeah, absolutely. So, I mean, really broad category of subject, but I will do my best to kind of keep it in the lane and keep it moving here. So, private equity has been involved for a long time, right? I think in the behavioral sciences, as you mentioned, Carl, there has been an increase in that activity, in that acquisitions or mergers, or even purchasing of bolt-on organizations to then complete a larger organization. And really, what we see in the research and what we hear out there don't really line up. And what I mean by that is the myth of it, just like you said, right? Everybody in private equity is bad and only out to get what they want, and patients and communities don't matter. That's not what I've seen. That's not what I've experienced. And I've been the CEO for both an applied behavioral analysis company and a community mental health center, as well as worked for several large behavioral health companies that were owned by private equity. And in each of those examples, the focus was always around the quality of the service being the driver to sustainability for that business, as it should be, right? I think we all agree that that is the fundamental equation that usually leads to good things. And the research bears out. I was looking this up, obviously, for our discussion today, but there's several articles over the last 2 years, and specifically in JAMA, specifically then again in Health Affairs and the Journal of Ethics, even where they go into cross-sectional analysis of outpatient residential mental health and substance use disorder treatment practices acquired by PE. And in another example, they're looking at specifically just ambulatory services acquired by PE. And they wanted to see of those, how many are doing well from an outcome standpoint, right? And so they looked at HEDIS measures and they looked at Medicare measures and they looked at different standards across healthcare. And what they actually found was that other than staffing ratios being slightly lower for the private equity owned companies, everything else was either at the same par or a little bit better, especially in behavioral health, substance abuse, autism. And so I'm speaking from that lens, if you will, but I think it's really important to understand that because oftentimes mental health services, psychiatric facilities, residential treatment services, and especially substance use disorder, you talk about stigma, right? All of those services have had that label, unfortunately. Seldom do families want to acknowledge their schizophrenic aunt who's at the state hospital and has been in and out of treatment for years. And so knowing that private equity has invested similarly across behavioral health now and actually at an increasing level since 2021, but has about the same good outcomes or better than some of the same acute care facilities that are not private equity owned is really substantial to understand. And it's quantified right across these studies. And I'm happy to provide anybody who's listening with those examples and they can look at them themselves. But, it's really fascinating. In fact, I didn't actually expect to find that just because I've heard so much of the other that's counter. And so I was fascinated that this is one of the things that is true. So between 2012, these are just some stats, and 2023, 642 mental health clinics and 1,152 SUD facilities were owned by private equity across the country. This accounted for about 6.2% of all mental health facilities and 7.1% of all addiction treatment facilities nationally. 3 states in particular had the highest private equity saturation. Those states are Texas, Colorado, and North Carolina, making up about 25% of the total of all of those facilities I just mentioned. So, overall, ownership in healthcare through private equity has grown rapidly across physician practices. We've seen hospitals acquired, we've seen clinics acquired, we've seen some insurance products acquired. But the bottom line is that, interestingly, what we're hearing, the noise we're hearing, doesn't actually match what we're seeing when the data is collected, the analysis is done, and researchers are taking a look at it. So I'm going to be paying close attention over the course of the year, of course, as some of these new policies, right, roll out through the government, the Affordable Care Act changes happen. Not to say that that will slant quality in this regard, but again, sometimes policy does lead to changes, and we need to be aware of that. So I'll be paying close attention as we go.
Ed, I just we have great guests on, and you are no exception. Your command of your topic is so great to work with. Thank you for bringing that to the table today. If our listeners want to get in contact with Ed and the services your company offers, how do they do that?
Yeah, of course. They can either email me at info@eshealthcareconsulting.com, or they can just visit my website and send me a contact form. That's www.eshealthcareconsulting.com.
And to our listeners, that information will be in the show notes. To our listeners, thanks for being with us today. And Ed, thank you so much. I am so looking forward to round two that will be coming up just as soon as our schedules can match.
Sounds great, Carl. Thank you.